Welcome to Nourish MD, Doctor Dietitian Dialogues, where doctors and dietitians empower you about your health and discuss and provide a better path to health and wellness. Proudly presented by Concierge Medical Practice Private Physicians Medical Associates, PPMA, with your hosts, registered dietitians and nutritionist, Lauren Papanos and Romana Brennan.
Hello, everyone, and welcome to the Nourish MD's podcast. I'm one of your hosts, Lauren Papanos, and I'm joined by my co-host today, Romana Brennan. We have a really special guest today, Dr. Masserman. He is going to be talking to us all about the conversation of menopause, how to determine if hormone replacement is right for you, why it might not be, some alternative options, some of the common symptoms and complaints that come up during this time of your life. So we are so excited to have this conversation with him. Dr. Masserman, welcome, and thank you so much for being here.
Thank you. I'm happy to be here.
Thanks so much for joining us, Dr. Masserman. I would love to just kick off the conversation and really hit the ground running. Why don't you share with us a little bit more about how can someone determine if they're within this perimenopausal time frame? Also, if you don't mind just sharing with us, what does that age range look like? What are some changes that someone might notice on their lab markers, and some indications, some symptoms that might indicate that they are entering this perimenopausal time frame?
Sure. So perimenopause is fairly, irregular. It's not specified. The average age of menopause meaning menses stop, menopause, is 50 to 51. So the average age range of women going into menopause is 45 to 55. So perimenopause is defined as that period before menses cease, anywhere from 6 months to 4 years before. I've had some patients saying, I've been in perimenopause since age 30, but that's not the case. Technically, it really is within a few years of the cessation of menstruation. Perimenopause is usually characterized primarily by irregular menses. As one ends the end of your reproductive years, you don't ovulate every month, and so cycles become irregular. Some cycles get heavy. Sometimes you'll skip a few cycles, and then you'll begin to have some of the symptoms that characterize menopause, like hot flashes, vaginal dryness, irritability, depression, sexual dysfunction, and there are not really good tests to say that you're in perimenopause, and there's even not a good test to tell you, predict exactly when you're going to go through menopause. When is your last period going to be? There's really no test. The test that we do for menopause is called FSH, stands for follicle stimulating hormone, and it comes from the pituitary gland, and it works inversely with estrogen produced in the ovary. So when estrogen levels are high, FSH levels are low, and conversely, when estrogen levels are low, FSH levels are high. FSH stands for follicle stimulating hormone, and it stimulates the follicles within the ovary to produce estrogen. And as the estrogen levels go up, FSH levels go down. But at a certain point in time, there's no estrogen, so FSH stimulates the ovary. There's no response. So more FSH comes, no response, and FSH rises again. And when it reaches a level of about 25 or so, that's pretty consistent with menopause. The strict definition of menopause is retrospective. That is to say, when you've gone 12 months without a menstrual period, you're officially in menopause. You don't necessarily have to do a blood test to test for that. So the other tests some people do in perimenopause, there's a thing called AMH, anti-Müllerian hormone, that are sort of a non-specific way of looking at quality and quantity of eggs. And as that AMH level goes lower, you understand you're getting closer to menopause, but there's still no specific thing to tell you. And that the treatment has to do with how severe your symptoms are. If you have a few hot flashes, that's probably not necessary to treat it. If they're fairly severe or significant hot flashes, but you're still having menstrual periods, one can treat that. And we use one of two things. You can either use very low dose estrogen to augment the amount of estrogen in your body since it's variable, or some people are now using a new ultra low dose birth control pill, most birth control pills are a combination of estrogen and progesterone, and they're low-dose estrogen, 20 to 30 micrograms of estrogen. There's a pill called loloestrin, which is 10 micrograms of estrogen. It's just enough to get rid of the hot flashes that one may have. And the other advantage is you're getting contraception. The problem, if one doesn't use contraception, is that you can still ovulate before you stop having your periods. And there are some oops pregnancies. My oldest patient was 53. She actually had come to the OB clinic with her daughter for her OB visit and said, I haven't had a period in a while. So we did a pregnancy test on her and it was positive. So I got to take care of mother and daughter pregnant at the same time. So until you actually are in menopause, you still need to use some form of contraception. So that's another medicine that can be used. And then if one's having dryness or irritation or other things, there's medications. And we talk about menopause, I'll go into more detail about those. The other thing is when someone comes in and says, I think I'm getting ready for menopause, I haven't had a period in a couple months, the first thing you need to do is to do a pregnancy test to make sure that they're not pregnant. And then you can check thyroid function because sometimes hyper and hypothyroidism can cause some of those premenopausal or menopausal symptoms. And you can also check for a prolactin, which is a milk hormone from the pituitary gland that can also cause some of those symptoms if it's not functioning properly.
Wonderful. That's super helpful. And can you just explain to women that maybe suspect they're going through perimenopause, how does this compare to what we see in menopause? Are there differences within these specific labs that you mentioned, like AMH and FSH and maybe even estrogen, that could provide more distinction between perimenopause or menopause? Do these levels change necessarily once there has been at least 1 year since the last menstrual period?
Well, FSH is the best way to diagnose menopause, and that FSH levels may rise a little bit as you're getting closer and closer. And then once they hit 25 to 30 and you've not had periods for a while, that's pretty consistent with menopause. Again, the strict definition is having gone 12 months without a period, and you can say you're in menopause. So within July of 2023, you had a period and haven't had one until now, you're technically in menopause. You don't need to do an FSH if you've gone a year, you've had that. Sometimes where I find FSH to be helpful is in women who've had a hysterectomy, where their uterus was removed, they still have their ovaries. So they're still producing hormone. So menopausal symptoms have to do with decrease in your body's hormones, which come from the ovary, not from the uterus. So in someone who's having symptoms, they don't have a uterus, you can't go by a last menstrual period because they no longer have menstrual periods. And I would do an FSH, and if it's 25 or more, then you can say to her, you're officially in menopause. And then depending on the degree of symptomatology, you then can decide whether you need to use treatments.
That's great. Thank you so much for sharing those numbers. I think that's going to be really helpful for individuals who maybe are feeling a little bit impatient as they're rounding the corner on those 12 months, or feeling like, oh, I went 10 months and then I got a period, or I went 11 months and then that clock kind of starts all over. And that's helpful also for individuals who have had a hysterectomy. So I appreciate you touching on that. So why don't we talk more about those common symptoms, common complaints of individuals postmenopausally? Let's start with hot flashes. Can you talk us through a little bit more about your approach in terms of managing those symptoms, whether it's hot flashes or some of these other symptoms that involve the nervous system?
So hot flashes are the most common, and they probably have to do with dilatation of blood vessels and an inpouring of blood into the body, and you get really flushed. Your face turns bright red, lasts for maybe a minute or so, and then sometimes you end up in a cold sweat, soaking your nightgown and having to go and change your clothes. I've had women who say to me, I feel warm all the time. I think I'm still in menopause. I think I've been in menopause since I've been 30 because I'm warm all the time. I think there's a subset of women whose internal thermostats are set a little bit higher and they feel warm, but that flushing thing is a discrete event that occurs lasting a few minutes or so. And as you get into the postmenopausal years, sometimes women are having 50 or 60 hot flashes a day, wakes them up at night. It's terribly disturbing. And then one has to talk about, treatments for that. In addition to hot flashes, the other thing that happens very commonly in menopause is vaginal dryness. Again, in the absence of estrogen stimulation, the vagina gets thinner and becomes drier, can cause irritation, and can cause painful intercourse. And there are medications that can be used for that. And we'll go into that a little bit later too. Depression can occur commonly with menopause. Insomnia, difficulty sleeping, sometimes because of the night sweats, sometimes just because of insomnia itself. And those are the classic symptoms that have to do with menopause. So again, I've had patients say, gee, I've been perimenopause since age 30. Not very likely.
And are a lot of these symptoms kind of collectively things that you refer to specialists for if someone is experiencing insomnia, or do you find more often than not, once we can really address some of the core and manage some of these symptoms better, we can do so, or you can do so, your team or whoever can really manage that from more of a hormonal perspective?
Family doctor, gynecologist, nurse practitioner can all manage those. And that, interestingly enough, most of those symptoms can be managed with one treatment. And we'll talk in more detail if you want. And that treatment is hormone therapy. And, I'm a big believer in hormone therapy. Hormones are good things. So for the symptoms of menopause, frankly, nothing is as good as estrogen. And that we'll talk about how it can be used, the different preparations for it, the contraindications to using it. And then for someone who either has a contraindication or is afraid to use estrogen, well, there are alternatives. But the truth of the matter is those alternatives are not as good as the estrogen.
Do you believe that all of those menopausal symptoms that you mentioned are all driven by that low estrogen state? Because I've heard once before that if you're still having hot flashes and it's been a couple of years since you've been through menopause, let's say like 3 to 5 years, it may not just be because of the low estrogen. It could be because of this like maybe activated nervous system state where there's maybe like high stress hormone production that's happening. Would you agree with that? Or do you think all those symptoms are really just driven off this chronic low estrogen state?
Correct, because there's a certain point where estrogen becomes almost zero and you're still having hot flashes. Some women will have hot flashes for 10 to 20 years, and that it's severe enough where they want to be treated. The interesting thing is that in the year 2001, there was a major study done called the Women's Health Initiative, which unfortunately will never be repeated. It was done on tens of thousands of women. We quote studies where there were 200 people in it or 50 people in it. But to be statistically significant, you have to have a large number. Well, tens of thousands of women is a huge number. And it was done by the then company that manufactured the most commonly used estrogen called Prempro, Premarin and Provera. Premarin is a type of estrogen. It comes from horses. Actually, Premarin stands for pregnant mare's urine. I'm old enough that I remember when that first came out. And Provera is synthetic progestogen. It's not progesterone, but it acts just like progesterone. So the theory was that we know the estrogen seems to be cardioprotective. It helps the heart. So that their question was, if we give women hormones, will it reduce the incidence of heart disease? So they started this huge study, and it got stopped because there was a higher than expected incidence of heart attacks and strokes. And that there was a major panic in 2001. Everybody was taking their patients off of estrogen. And then when they went and took a closer look at it, it turned out that when you do a study, you have to apply certain variables and discount using your medicine because of those variables. Well, the main variable was anyone who had hot flashes were not in the study. Well, who has hot flashes? Younger women going through menopause. So the average age of the study was women who were 63. Well, after age 60, your coronary arteries calcify, and you will have a higher incidence of stroke and heart attack and so on. So that from that, we learned that it took several years to learn and to get some of our patients back on hormones who were really miserable from a quality of life point of view. That if you started hormones right around the time of menopause, you may decrease the incidence of heart disease as well. So that was kind of a long diversion, but that's sort of the history of how hormones work and how I think estrogen primarily is the driving factor. There are other things that probably are helpful too, but really that's the main thing. Now, the other thing, as long as we're talking, in the very beginning, years and years and years ago, when people went through menopause, they were given estrogen. And they developed about 6 times an increased risk of uterine cancer. Why? Because unopposed estrogen will overstimulate the inner lining of the uterus and cause precancerous and cancerous changes. And what's a good estrogen antagonist? Progesterone. So that we realized that if we give women estrogen and progesterone, you will reduce the incidence of endometrial cancer, and that they should do fine. And sure enough, it did do that. But there were other problems by adding progesterone as well. One of the Women's Health Initiative studies showed that women on combination hormones of estrogen and progesterone did have an increased risk of breast cancer. But what's interesting is that probably progesterone is a culprit. Progesterone probably can take precancerous cells and turn them into cancer, and then estrogen will spread it faster. So women who've had a hysterectomy don't need the progesterone because they don't need protection of their underlining of the uterus. They just need estrogen alone. And in those women who were just on estrogen after menopause because they had a hysterectomy, their incidence of breast cancer was less than those who are on a combination of estrogen and progesterone together. So that there's goods and bads to everything. There are great benefits, and then at some point we'll talk about the risks and side effects of being on those medicines.
Fascinating.
Yeah, why don't we just keep this conversation going and continue on the vein of hormone replacement therapy and who might this be a good option for? Understandably so, there's a lot of nuance to this conversation. So why don't we just dive into that? Who is this right for? Who is this not right for? What are some of those other considerations that we need to take into account?
Good question. So when I was a new young resident many years ago, believe it or not, what we would do is when a woman reached menopause, she was handed a prescription for hormones. Take these, they'll make you feel better. No one waited for symptoms. We just said, you need to be on hormones, go on them. And then we saw the side effects that come from being on hormones, from breast cancer to uterine cancer to heart attacks or strokes and so on in older women. So we now are much more careful about how we prescribe to, and really it has to do with one's symptomatology. If a woman comes in, as we take a careful history and says, my last period was 2 years ago, I have a few hot flashes, nothing bad. I'm sexually active, but it's working okay. I don't feel too dry. She doesn't need to be on hormones, on any kind of hormone. But the woman who comes in, on the other hand, and says, I'm having 40 hot flashes a day. I can't sleep. I'm depressed all the time. I'm dry. I can't have relations with my husband. Life is horrible. She's the person you want to put on hormones right away. And believe it or not, she'll start to get asymptomatic with a matter of days, if not weeks. And that there are various preparations for both estrogen and progesterone. Classically, they were put on Prem-Pro, which was a combination of Premarin and Prevera, as we talked about before. And they would take that every day. Sometimes people would try to mimic the menstrual cycle and do it cyclically. Well, cyclically, your body produces estrogen all month long and progesterone the second half of the cycle. But that's really during your physiologic years, the reproductive years, the progesterone is preparing the endometrium for implanting pregnancy. Well, we're not talking about needing implanting pregnancies, but some people thought you should try to give hormones cyclically. So we would do it 25 days of estrogen, 14 days of progesterone, then stop. One of the problems with that is that for the average person, and it's hard for me to take pills, to try to take them on a certain schedule like that is not very easy. And when you give estrogen, progesterone, and then stop them, what happens during the menstrual cycle? You stimulate them with hormones, you stop them, and you have a period. So here are these women who've now finally gone through periods. They've given away their box of tampons, and here they are having menstrual periods again. So that was not very popular. So we've now begun to give people continuous hormone therapy, estrogen and progesterone together. And depending on the side effects and risks, sometimes progesterone can cause depression, can cause abdominal cramping, cause constipation. And so that some people can only take their progesterone every couple of months, which is fine. As long as you were antagonizing the stimulatory effects of estrogen, it's okay to take progesterone periodically, even though you might have a little withdrawal bleeding. So most people will take their hormones regularly. Now you can take them in pill form. There's also a patch. Problem with a patch is that there's only one patch that has estrogen and progesterone in them, so that if you're using a patch, you're taking a patch and you got to then take progesterone pills anyway. The other problem with the patch, and I like the patch, is that the adhesive can be irritating. You switch, the smallest patches you use twice a week, and you change from one side to the other side. But when you take them off, you can have redness and irritation and soreness from where the patch was. So some people are using vaginal hormones. I'm still a pill guy. As we get older, we're all on bunches of pills. So taking an additional pill isn't such a big deal, I don't think. So when I give hormones, I usually will give them, and I'll explain later why, but I'll give them estradiol, which is the main estrogen, 1 milligram every day, and micronized progesterone, which is small molecular progesterone, also every day. As long as they tolerate that's good enough. We can change the regimen accordingly. Some people, as I said, who've had a hysterectomy just need estrogen alone, and for them the patch is fine. They just use it twice a week, and they're good with that. Another issue that I thought I'd stick in now is that people have talked about bioidentical hormones, and they go to compounding pharmacies where they compound them. There are a couple problems with that. Now, your body makes 3 kinds of estrogen. There's estrone, estradiol, and estriol, of which estradiol is the most important, and progesterone. So compounding pharmacies will get raw material from somewhere, whether it comes from yams or something else, and they will then compound it either in pill form, capsule form, liquid form for injections, and intravaginal form. But the problem is compounded bioidentical hormones are not FDA regulated, so that the pharmacist, is an honest person. He or she's going to make whatever they're supposed to make, but the raw product they get may be such that you're getting 1 milligram of estrogen 1 month and 3/4 of a milligram the next month. You may be getting progesterone that you form into a cream or a paste and you rub it on your arm. The problem is that the bioidentical progesterone are large molecules and they do not get absorbed into the body. So that while you think you're taking estrogen and progesterone, you're really taking unopposed estrogen because the progesterone is not being absorbed. So I try to explain to my patients that if they want to use bioidentical hormones, they have to just be aware of the fact that they've not been approved. There's no studies, and there never again will be a study like the Women's Health Initiative to prove what's better than the other. So I give them what I call pharmaceutical grade bioidentical hormones. Like I said before, I will give them estradiol, 17-beta estradiol, a pill, 1 milligram every day, together with micronized progesterone, which is the exact same chemical compound as progesterone your body makes, but it's in smaller molecular structure so that it's more easily absorbed by the body, and that works just fine. Yes, it's 2 pills to take, but it's not a big deal. Mm-hmm. So that's hot flashes and hormones.
And you mentioned earlier about the Women's Health Initiative, how it was done in older women that had gone through menopause, maybe 10, 15 years prior. Are you recommending that women, if they are, say, 15 years post-menopause, that menopausal transition, Is starting hormone replacement therapy still something that's in the cards for them, or can this only be safely administered and protective if it's started at the onset of menopause?
Well, I mean, it's going to work better from a cardioprotective point of view the earlier you start it. The recommendations, however, are not to start hormone. That within 10 years of menopause, you can start hormones, but you should not start on hormones after the age of 60 because of the fact, like that study showed, that you're at higher risk for cardiovascular events, stroke, heart attack, blood clots, and so on. So someone who comes in at 60, now, by that time, most people have gotten their hot flashes taken care of or they're on medication for it. So the question is, do you leave people on longer than age 60 as opposed to starting them? So I won't start patients on hormone therapy after age 60 because usually by that point, their symptoms don't warrant it. If, however, someone's been on, and some women will have hot flashes, as I mentioned earlier, for 10 to 20 years. So you can't say, oh, the clock's done. You have to stop all your hormones now. I mean, I would try to taper them if I can to a lower dose or a less frequency. If they're taking a patch twice a week, I'll say take the patch once a week. If they're taking the pill every day, I may say take the pill every other day, and over time gradually try to taper them. But there are a few women who just don't do well when they stop their hormone therapy, and I will leave them on longer. But I mean, I do informed consent and say you understand that you're running the risk of heart attack, stroke, breast cancer, etc. And that if you feel that quality of life issue overrides the potential medical issue, I've had people that I've left on into their 70s who've done well. Now, a patient who comes to me and says, this estrogen does great stuff for my skin. I don't have hot flashes. I don't have any dryness, but I like having good skin. That's really not a good reason to stay on hormones. And I do my best to talk them out of using them at that point.
Is there any other contraindications to hormone replacement therapy for someone that is in the first 10 years of menopause? You mentioned if someone's had a hysterectomy, then progesterone replacement would be contraindicated. But is there ever any situations where no woman should be on hormone replacement therapy at all?
Yes. So progesterone is really only used if you have estrogen. After menopause, there's no reason to get progesterone. Progesterone's main job is during the reproductive years, it primes the inner lining of the uterus for an implanting pregnancy. Well, near menopause, you're not looking for an implanting pregnancy. So that estrogen alone is fine in women. So it's not contraindicated for progesterone. You just don't need it. So there are contraindications. Hypertriglyceridemia, if you have very high triglycerides, you're at a higher risk for stroke. Active gallbladder disease is another one. Family history of thrombophlebitis. There are people in the family who've had blood clots at a younger age or stroke at a younger age, and you've carried that gene. It's absolute contraindication to go on hormone therapy. Or if you've had a blood clot yourself, contraindication. If you have a history of breast cancer or liver disease, you shouldn't go on it. Now, early uterine cancer, since the treatment for early uterine cancer is a hysterectomy, the cure rate is virtually 100%. So there's no reason, even though you've had uterine cancer, not to put them on hormone therapy for treating the symptoms. If, however, it's a more advanced uterine cancer, then that's not someone who should be on hormone replacement therapy. So glad you asked that. So yes, there are contraindications relative and absolute to being on hormone therapy.
And when you have someone on hormone therapy for any particular period of time, are you adjusting the dosage? Is that based on symptoms? Are you doing hormone testing to make sure that you have that dosage right? Or naturally, is that something that's going to be adjusted?
So, the rule of thumb in medicine used to be the lowest dose for the shortest period of time. And that's still kind of true. The idea is if you can put people on hormones and by 5 years taper them off, that would be ideal. The women I talked about in their 70s, they're really a subset that are exceptional. In most cases, you're going to be able to get them off hormones. And most women are a little bit nervous. I hear about breast cancer and I I don't want to stay on them forever. And I have other women who say, I need it for my well-being. I mean, I'm depressed all the time. And as soon as I get off the hormone, things are bad. As soon as I go back on them, my symptoms get better. So I usually keep them on the same dose. And what I'll try to do if I try to taper them is have that same dose, but change the frequency. Like I said, I would take one pill off maybe every week for a while, or go from patch twice a week to a patch once a week. And then at that point, if they really want to go off, you shouldn't stop it immediately because they may well get symptomatic again. So you want to do a slow taper, and in most cases, that's going to be enough.
Enjoy high-quality supplements shipped right to your door with full script through Private Physicians Medical Associates, PPMA. Reap the health benefits of pharmaceutical-grade vitamins while saving 5% on all orders. Set up your free PPMA account today. Visit privatemds.com.
So if you don't mind, let's talk about another major symptom of menopause, and that's vaginal dryness. For many people, it can be irritating and sore, and for other people who are sexually active, it really can inhibit their sexual activity because it feels like sandpaper. So that, again, for someone who's having hot flashes and dryness and depression and irritability and all that sort of thing, systemic estrogen works fine. Someone who's not having hot flashes, but maybe just having dryness, then there are things you can do intravaginally that help. Starting with the easiest thing is you can use vaginal moisturizers. And it does what it says. It moisturizes the vagina so it doesn't feel so irritated. And you don't need a prescription. There are a lot of them that are over the counter. My favorite one is a drug called Replens, from the word to replenish. It replenishes the moisture in the vagina. You just need to put an applicator full in 3 times a week, and that does the job. For people who are having painful intercourse, then you want to use lubricants. So there's a difference between moisturizers and lubricants. A moisturizer keeps the vagina moist. The lubricant actually prepares it for sexual activity so that it's not going to be rubbing and causing irritation. And there are a number of things, again, over the counter. You don't need a prescription for them, different kinds of gels and oils and so on. Some oils you got to be careful of because if you're in the perimenopausal years, they can dissolve part of the latex in the condom. So that's not a good thing to do. So my favorite lubricants are olive oil. I have Mediterranean patients who swear by olive oil. But my favorite of all is coconut oil. And you take it comes in an emulsion, and you kind of melt it in the microwave, and it's liquidy. It has a fragrant odor to it. It tastes okay, and it's a great lubricant. There are pills that will help vaginal dryness as well. There's a thing called prasterone, which is DHEA, dehydroepiandrosterone. That helps dryness. There's a thing called osphine, selective estrogen receptor modulator. So it works like estrogen in terms of lubricating the vagina, but it doesn't increase your risk for uterine cancer. It can increase your risk for blood clots. Some people who don't want to use any kind of medication have used mind-body treatments, stress reduction, deep breathing, relaxation, yoga, acupuncture has been used, hypnosis has been used. And lately, people have talked about using laser treatments, so-called vaginal rejuvenation. Again, it's not been well studied, and that because of that, of course, insurance companies won't cover that, and it's quite expensive because you have to laser frequently. But the idea is that you're rejuvenating the vaginal mucosa, and therefore you can have better lubrication, and it will be more helpful. So there is a study ongoing now at UC Irvine in the Division of Urogynecology, together with the Beckman Laser Institute, looking at certain kinds of lasers of what they can do in terms of helping that and trying to do a good enough study so that they can publish it and say, yes, it is worthwhile. So for now, it's being used, but really still off-label.
Wow. Sounds like a very progressive and hopeful potential option for women. Thank you so much for sharing those. Dr. Masserman, you provided so much great information in this discussion. We really appreciate it. And I really think that there's so many patients and women out there that are struggling in this area. There's a lot of confusion. As you mentioned, the Women's Health Initiative, I think it raised a lot of questions that maybe some people are still fearful of. And I think that sometimes people are also provided conflicting information from maybe their own physician or what they hear in the media. And so I really appreciate the evidence-based recommendations and all of your years of experience too, that you can provide to this conversation. For women that have listened to this and are looking for a physician like you that can really provide them with the right support that they need, can you tell them where they can maybe either learn more about working with you or another physician that you would recommend, or a physician network that would be a great place for them to start?
Sure. Well, I actually am retired. So just don't want to drop by my house one evening. I'm pretty much out of the action. I still teach at UC Irvine. I run the OB clinic with the residents, but I'm not really practicing anymore. But I'm happy to talk to people if they need to. But then again, you can talk to your local gynecologist, because most gynecologists understand hormone replacement therapy and other alternatives for treating menopause. Some people will have read more and will consider themselves menopausal specialists, but it's like, do you consider yourself a baby delivery specialist? It's part of what the specialty is, and you should be able to handle all of the issues during a woman's life cycle, including that. So, you can go to some family doctors, are comfortable talking about that topic as well, but you want to see a specialist who deals with menopause, perhaps. Let me talk about one other area that we didn't hit, and that is, what about women who either have contraindications to being on hormones or are afraid to go on hormones and still are having symptoms? Are there alternatives we can give them? And again, as I said in the beginning, nothing is as good as estrogen, but there are things that are helpful as alternatives. Some of the antidepressants, the SSRIs, selective serotonin reuptake inhibitors, of which Prozac is part of that group, but Prozac is not that good. The best one for it is an antidepressant called Paxil. And it turns out that when they were doing the studies on Paxil, they found that in very low doses, hot flashes got better. So Paxil comes in 25 milligrams and higher. There's a pill called Brisdil, which is 7.5 milligrams and works fine, not as good as estrogen, but works well for many women who are having hot flashes. So that's an alternative. It's a prescription medication. And some of the other Celexa, Lexapro help some, but Prozac and Effexor really, or Zoloft don't have any effect in terms of hot flashes. Another option is a medication called gabapentin or Neurontin, which is used for seizures. Take it at bedtime. Tends to make you sleepy, so that if you're having mild hot flashes, it'll help reduce those as well. Some people have tried progesterone with variable success. The good thing about progesterone, I didn't mention that earlier, is that women who are having insomnia, progesterone is a somnolent pill, meaning it makes you sleepy. So that if you take it before you go to bed at night, you'll probably sleep better, which is when I give my patients their hormone replacement therapy, I tell them, don't take your progesterone in the morning or you're going to be sleepy all day long. Take it at night before you go to bed. Okay. So what about plant-derived estrogens, so-called phytoestrogens, soybean, red clover? There's not good data. Some people have some relief with them, but really I'm not that impressed. And the other herbal medication that people have talked about using over the counter is black cohosh. Black cohosh has some estrogenic properties, but the data doesn't show it to be all that effective. Interestingly enough, it does stimulate the breast a little bit, so that I'd be careful using that in women who've had a history of breast cancer. Good. Now they got the cover.
Yes, thank you. Thank you for making sure that we touched on that. Appreciate it. Okay, Dr. Masserman. Well, thank you again so much for your time and sharing all of your wisdom today. It's been so great to talk with you. And thank you for all the work you've done over the years as well. And we hope you have a great rest of your day.
Thank you so much.
Thank you for joining us for today's episode of Nourish MD, Doctor Dietitian Dialogues. This podcast is intended for general educational purposes only. It is not a substitute for professional medical advice. Please consult with your healthcare provider before beginning any nutrition or supplement recommendations. Sign up for our mailing list so you'll never miss an episode of our wellness journey. See the podcast description for the link.